call myself a laparoscopic oncologist, and I practice in Northern California. And I want to ask the conference producers, how fair is it to make me, a surgeon who works with her hands, follow a chemical engineer who obviously works with his brains? I just don't think that's very fair. But anyhow, as it were, I'm going to go ahead today and talk about the unspeakable thing that I think we should all embrace for, and I need to make this very clear, for the post-fertile woman. Nothing I'm about to say applies to women seeking and desiring to maintain their fertility, okay? So that said, what procedures should we be offering women having gynecologic problems? Well, obviously, it should be the procedure that offers the maximum success to address the problem. Yes, almost every single procedure should be done laparoscopically. Now, last year at the meeting, we established that while I am an oncologist, I take care of complex gynecology and cancer problems in gynecology, but I think last year we established I was a benign gynecologic oncologist, if those aren't oxymorons. But everything should go minimally invasive. But we also need to have, and this is what I'm kind of going to address today, a more purposeful view towards preventing future problems and preventing future surgeries. Now, none of us think, oh, you know, I'm going to get breast cancer when I'm 60, and I'll probably have excessive bleeding when I'm in my late 40s. So, I mean, nobody thinks they're going to have a surgical problem. But we do have surgical problems, and nobody expects a cancer, but we do get them. So we need to plan in our practice. So this is why most of us oncologists think that a supracervical hysterectomy is kind of chipping away at your patient and is never essentially a good choice. It doesn't change sex, continence, or support. A woman continues to need PAPs, and in this day and age with 50% of marriages ending up in separation and divorce, women are going out into the field, encountering new men, everybody's sharing their viruses. And then still, the cervix, the retained cervix can bleed, it can develop endometriosis, it can prolapse. And they have to use estrogen plus progesterone, HRT, which we'll talk about and show increases risk of breast cancer and heart attack. So, and it's not optimally oncoreductive. So for us oncologists, we think supracervical is never a good choice. Endometrial ablations, again, I think if we had a subcommittee at the Society for Gynecologic Oncologists, we'd say this is never a good choice for a patient. The only good thing about an endometrial ablation is that you get a facility fee. So with endometrial ablation, I know not everybody's going to agree with me. I know. But when would you offer a patient and tell her up front, there's a 40% chance this won't work and that you will need a hysterectomy? Because that's what you have to tell a patient heading into an ablation. So for that reason, I posit that in the post-fertile woman, and you wouldn't offer an ablation to anybody who's fertile, but who desires fertility, this is never a good choice. Now, in America, obesity is becoming more and more of a problem. And morbidly obese patients, BMIs greater than 40, have a 50% chance of getting cancer. And these three body mass groups comprise 2/3 of American women. So I would say as an oncologist, any effort to retain a part of the uterus is not in the patient's best interest, even if she doesn't, even though she would like the most minimal procedure. I think it's up to us to explain to the patient that hysterectomy, the worst thing about it, they think it will change their sexual enjoyment. Sex is either better or unchanged for about 98% of women having a hysterectomy. In the Women's Health Initiative, at 6 years, the women on any form of HRT were more sexually active. And I think that's a good thing. Okay, and hysterectomy doesn't harm support. From the Women's Health Initiative baseline data, the continence is roughly the same, whether they long ago had a hysterectomy or had not yet had a hysterectomy. Menopausal symptoms, though, the need for hormone replacement therapy and relief of those last a lifetime for some 10% of us, and up into our late 60s for nearly a quarter of us. And so maintaining the uterus such that you actually have to take estrogen plus progesterone will increase the risk of breast cancer over placebo. If a woman does not have her uterus and she takes estrogen only, then she would be in this lower category. So if you're a patient starting hormone replacement therapy and taking it for taking it for 5 years or however many years you need it, at 10 years, your risk of breast cancer is going to be much higher if you have your uterus in place versus if you didn't. The difference is about a 50% drop in breast cancer. So leaving any portion of the uterus would put you in this category rather than this one. So breast cancer deaths on placebo, and actually all-cause mortality, are higher than on estrogen alone. So estrogen is not the foe of post-reproductive women. It is not the cause of cancer. Now, taking oral estrogen plus progesterone increases your risk of DVT, breast cancer, myocardial infarction, and pulmonary embolus. On oral estrogen, it decreases breast cancer and myocardial infarction. And oral estrogen, these two areas in yellow, are still increases caused by oral estrogen. But if you go to transdermal, which, you know, in California, it's bioidentical, and bioidentical transdermally is very, very safe. And it actually does reduce or not change stroke and deep vein thrombosis. Even in the woman who has clotting mutations, the use of transdermal estrogen doesn't increase it. From the Esther study, women with mutations had the same risk. Oral certainly increases it. Women with no mutation have the same risk for deep vein thrombosis, and obese women have the same risk. So transdermal estrogen seems to be a very safe option for the future, but you can only take it if all of your uterus has been removed. So if we gave transdermal for menopausal symptoms, it prevents uterine, tubal, cervical cancer, of course, reduces breast cancer, osteoporosis. Estrogen, I think in my very next slide, no, in a later slide, I will show you, is as good as any of the bisphosphonates. And it also reduces heart disease and has no effect on these. So I'm not finding a serious danger. Okay, so we've talked about how it's not I think, in a woman's best idea to keep a portion of her uterus if some other portion is giving her trouble. Let's not chip away at her. But what about the ovaries then? Am I so mean that I would castrate a post-fertile woman any chance she had? I would offer it. Certainly with every hysterectomy and the post-fertile woman, I would look for why she might, not every woman does, but why she might have the possibility of a benefit from having her ovaries removed. We know from the BRCA population that removing the ovaries reduces breast cancer by a mean of 50%. Removing the ovaries reduces breast cancer. Now, maybe that's because we're removing a woman's endogenous sources of progesterone, because progesterone seems to be the only hormone we've talked about that increases it. I'm not sure. And yes, certainly there's the ovary cancer reduction. But what about non-BRCA women? Well, it has been studied. Removing the ovaries of BRCA negative women also reduces the likelihood that they will get breast cancer. In fact, in the Women's Health Initiative, the women who took estrogen alone had a 77%, but look at the risk reduction in breast cancer of 0.7, 0.4, 25% reduction by 75%. So this is a benefit to women who come from families that are not BRCA positive, but who have a lot of women with breast cancer. Say your mother had breast cancer when she was 44 and you've been tested for BRCA or ATM and PAL-B2 and all the other things, and you don't have any of those. Well, if your ovaries are removed, your risk of breast cancer is significantly reduced. All right, now, why else would you want to remove an innocent young woman's ovaries? Well, PMS really affects many women. 5% meet the criteria for a psychiatric disorder, but 20% have severe changes that make them say things they regret to their children, to their husband, or at work, having to take it back. And it's very painful to know that you're not yourself a portion of the month. It's embarrassing, it's disempowering. If you remove the uterus and the ovaries and give pure estrogen, there is a complete resolution. This is solely caused by ovulation. Solely caused by ovulation. So transdermal estrogen is good for vasomotor symptoms, cognitive function is retained, bone density is maintained, sexual function's the same, cardiac risk is lower, breast cancer risk is reduced. So it seems to be a good idea. And then here's the slide that I want to say shows that estrogen is as good as the bisphosphonates, maybe even better. Better than SERMs, better than calcitonin. So what about sexual enjoyment? Well, in the menopause, we women, age 50, 60% of us are still active, meaning we don't just lay there, which is good. Okay, that was a joke. Come on. Were you all chemical engineers? Okay. We're going to have to dance together. Okay, so 60 to 69, we have a half shot at still being active. 70 to 79, a quarter of us are still active. And of those of us who are unhappy with our sex life in these waning years, it's because slightly more than half of us wish we had more. So these are good signs. But vaginal atrophy is epidemic, and women come in and out of the doctor's office being diagnosed with vaginal atrophy without a prescription for vaginal estrogen. And if a woman is on any form of hormone replacement therapy, she's more likely to report good activity. And that last sentence is from the Women's Health, all of that's from the Women's Health Initiative. So for the post-fertile woman who has endometrial polyps and irregular bleeding, I wouldn't lift a finger to do a polypectomy. For the post-fertile woman with endocervical dysplasia that won't go away, that's not malignant, I wouldn't lift a finger to do a cone. For fibroids, I would never do a myomectomy for the post-fertile woman, and I would not do an endometrial ablation to reduce her bleeding. I would say that for your brightest, healthiest, best future, you want to remove your entire uterus and all of your fallopian tubes. The fallopian tubes, as we know, being now identified as the cause of ovarian cancer. Now, whether the ovaries are removed or not, certainly that would depend on, the individual story that the woman has and whether she'd like to reduce her risk of breast cancer. But this is the discussion that we need to have once a woman is post-fertile. So the global endometrial ablation and the supracervical, they just don't hold a candle up to the total laparoscopic hysterectomy and, bilateral salpingectomy at a minimum, possible oophorectomy. So if you need surgery, I think the future is needlescopic. And an ounce of pretension, we know, is worth a pound of manure, but an ounce of prevention, pound of cure. So thank you all very much.